in this SARS-2 COVID-19 pandemic, the role of ABG has got pertinent. In one webinar by one organization, I asked the speaker that what is the use of ABG in this COVID-19 infection. He answered me that it is used in ICU. This is not the limitation of ABG. It is why I thought that I should give information about the role of ABG in moderate to severe COVID-19 infection. You know, almost all patients who are being admitted through emergency department are indication for ABG, where the point of care present in the emergency department. The COVID-19 infection, in this case also, the moderate and severe cases are being admitted through emergency department. And the second thing, you are well aware that a case of dyspnea, 3 primary investigations must be done in the emergency department, and those are ECG, ABG and X-ray chest. So both the condition says that ABG is must to be done in the emergency department when the patient of COVID-19, because you know the COVID infection is suspected when a patient comes to you with fever and acute respiratory distress. So they have dyspnea, so in all cases ABG indication is there, but prediction of ABG must not be done separately. It is the clinical diagnosis of the doctor which should be correlated with ABG diagnosis, and then the further management plans should be done in the cases. So what is the role of ABG? The ABG, it helps in diagnosis, it tells about the prognosis of the patient, it helps in the management plan, it is a monitor of ventilated patients, and not only that, it tells you about the early referral of the patient. I give you a simple example to understand the thing. Suppose there is a patient of COPD. The severity of COPD, they have given by the GOLD criteria and NICE criteria, depending upon the spirometry, it has been categorized as mild, moderate, severe and very severe cases. But a patient, when comes with the exacerbation of COPD due to COVID infection, the doctor thinks that how I will categorize it is not written, that how you will categorize the acute exacerbation of COPD when it comes. So the management varies from person to person. If you do a simple ABG in that condition, you know, in a COPD, when there is a rise of carbon dioxide, the kidney compensates for this rise to maintain the pH by conserving bicarbonate. So the bicarbonate level is high. So in a COPD, pH is normal, CO2 is high, and at the same time bicarbonate is high. When there is acute exacerbation, in that condition CO2 and bicarbonate is high, and at the same time pH is low, because for the compensation of the kidney for the respiratory problem, it takes 24 hours to 72 hours. So it takes 3 days to compensate. So in acute exacerbation cases, the kidney is not in position to compensate for the change in COPD, CO2, and so the patient have low level of pH, so the patient have acidosis. So if a patient is suspected to be acute exacerbation of COPD, the CO2 will be high, the bicarbonate will be high, and the pH will be low. Now this pH will say you that how you have to manage and what is the severity. If the pH is 7.4 to 7.3, it is a mild case. If the pH is 7.3 to 7.2, it is a moderate case, and if the pH is less than 7.2, it is a severe case. So, the management of mild case is give oxygen 1 to 2 liter, 24 to 28% through nasal cannula, face mask or the Venturi mask. In the moderate case, you have to use the BiPAP, non-invasive ventilation BiPAP, where there is inspiratory and expiratory pressure, inspiratory pressure for ventilation and expiratory pressure for oxygenation. The inspiratory pressure should be 15 to 20 and the expiratory pressure should be 5 to 10. Above that, you have not to increase. So, in the moderate case, you use non-invasive ventilation, that is BiPAP. And in the severe case, where the pH is less than 7.2, you have to use ventilator. Directly ventilator. No patient can be survived without giving ventilation to the patient. And on this, the severity of hypoxemia matters. So, if I am in periphery and if I am managing such case, acute exacerbation of COPD, in that condition, if I am managing in this way and if the patient is not improving, the carbon dioxide is going to up, in that cases, what I will do? I will early refer the patient to the higher center, tertiary center. So, what you have seen in this simple example, that it have given you the diagnosis because a patient of COPD, when have viral infection like COVID, cannot cause the rise of COPD and low of the pH. It can only simple hypoxemia they can produce due to the ARDS and whatever the thing is. So it says you about the diagnosis. It has shown you about the severity of the disease. The third, it has given you the idea how you will manage the case. At the same time, in the cases of COPD, your purpose is to maintain carbon PaCO2 less than 52, PaO2 more than 52, and the pH 7.3. So the time and again you will do the ABG. So it tells you about the monitoring of the patient, and at the same time it tells you about the early referral. This is the simple one example which I have told you that ABG is going to help you in the management, prognosis, diagnosis, referring, and all these things. Now one by one I will talk about that in detail. So I told you that it helps in diagnosis. Whenever you get a ABG at the point of care in the emergency department, that ABG should be analyzed in different heading. That is, one is your accuracy of ABG, gas analysis, electrolyte analysis, acid-base analysis, and lastly the final conclusion to correlate with the clinical finding. So, here, the involvement is of the lung. So, the gas analysis is very important. So, what things gas analysis says? It says you about the type of respiratory failure, the cause of respiratory failure, the severity of hypoxemia. It tells you about the relation between PaO2 and SpO2. In the cases of anemia, you have to calculate the oxygen content and the other diagnosis which you have got through the electrolyte analysis and the acid-base analysis. That also will correlate with you, because a patient of COVID can have associated comorbidities, and from the very beginning, if the ABG says that the patient have another finding, then you will be alert to manage that. We will deal of all those things in the next slide. Now the type of respiratory failure. As you know, it has been divided into two types, type 1 respiratory failure and type 2 respiratory failure. When there is hypercapnia, either with or without hypoxemia, does not matter. If there is hypercapnia, it is type 2 respiratory failure, and without hypercapnia, if there is hypoxemia, it is type 1 respiratory failure, in which I will say you that when there is metabolic alkalosis, there is associated respiratory acidosis. So the compensation can occur, but this compensation will not go beyond 49. So in the normal value, the PaCO2 is 36 to 45. This more than 45 can be due to compensatory effect of the metabolic alkalosis, but if it is more than 49, it is always primarily due to lung disease. And there should be associated hypoxemia, and that hypoxemia can be mild, moderate, and severe. Now, the cause of respiratory failure. You know, there are different causes of respiratory failure which can be shown by this ABG in simple ABG. So, what are the causes of respiratory failure? One is hypoxemia, another one is hyperventilation, third one is ventilation perfusion mismatch, the fourth one is shunt, and the fifth one is diffusion defect. All the things can be detailed by ABG itself. So here I have written the ARDS, because ARDS is the specific finding in the cases of COVID infection, and this ARDS have both the things, ventilation perfusion mismatch and at the same time shunt. So the things, now how you will proceed for diagnosis of this. So if a patient's ABG have been found, you have to see the carbon dioxide level. What is the carbon dioxide? If the patient carbon dioxide and at the same time, if you see the FiO2 and the hypoventilation. And the third one is difference between the oxygen PaO2, A means alveolar and a small a means arterial. So the value of PaO2. If a patient have carbon dioxide not increased and the Pa minus A, alveolar minus arterial oxygen is normal, which is less than 15, it is not due to parenchymal disease. It is due to low FiO2, which you get at the higher places. The hypoxemia, which you get at the height. So, in the same fashion, if a patient have PaCO2 high, and at the same time the PaO2 is normal, it means the patient have no parenchymal disease. It is due to decreased ventilatory drive, and that can be from the CNS to neuromuscular junction. If there is disease from the CNS to neuromuscular junction, to decrease the ventilation drive, there is decreased rate of respiration. In that condition, carbon dioxide will go and it will cause type 2 respiratory failure. But if the Pa minus AO2 is reached more than 15, so this can be due to ventilation perfusion mismatch, or this can be due to your shunt. So how you will differentiate the shunt with that of ventilation perfusion mismatch? You give 60% of oxygen through CPAP to the patient for 2 hours. If the oxygen improves, it is shunt. If the oxygen improves, it is ventilation perfusion mismatch. If the oxygen does not improve, it is shunt. So shunt and severe hypoxemia again becomes a indication for ventilator. So in the same fashion, in the cases of increased PaCO2, if the patient have Pa minus AO2 is increased, in that condition, it can be due to parenchymal disease. So this parenchymal disease can again due to ventilation perfusion mismatch and shunt. In the same fashion, you give oxygen. If it improves, it is ventilation perfusion mismatch. If does not improve, it is shunt. And if partially improved, it means there is associated ventilation perfusion mismatch with shunt, which occurs in the cases of ARDS. Now, PaO2, this is alveolar oxygen. This you can calculate by 150 minus 1.25 multiplied by carbon dioxide. And the difference between alveolar and arterial oxygen, you can derive from a simple value, age by 4 plus 4. Age of the patient divided by 4 plus 4 is the value of the difference between alveolar and arterial oxygen. The normal value of PaO2 is, it is written 9680, no, it is 100 to 105 millimeter of Hg. Okay? Now, in the cases of ARDS, I told you I have a specifically written ARDS because in COVID, you are well aware that there is injury of the arteries, or you can say there is injury of the epithelial cells of the alveoli and the capillary alveolar capillaries, endothelium of the alveolar capillaries. So there is injury of this. So there is exudation, and this exudation accumulates in the interstitial space and that of alveolar space. Not only that, neutrophilic sequestration and the thrombi formation and microembolism associated, all these findings can cause the myoproliferation and ultimately fibrosis. So the patient have both the effect. Patient have shunt and at the same time ventilation perfusion mismatch in the cases of your ARDS. Now this ARDS has been categorized into 3 parts: mild, moderate and severe. The mild is 200 to 300. The moderate is 100 to 200, and the severe is less than 100. So this ARDS has been classified as a mild, moderate, severe depending upon the hypoxemia index. This P by F is known as hypoxemia index as a mild, moderate and severe. The second one is severity. Depending upon the severity of the condition, that is type 1 respiratory failure, the severity, the COVID classification has been given as a asymptomatic, mild symptomatic, moderate symptomatic and severe symptomatic. So the mild case is if PaO2 is 60 to 80, moderate is when PaO2 is 40 to 60, and the severe one is a PaO2 less than 40. So this is classification. Now this table say you the relation between PaO2 to that of SpO2. In the cases of PaO2 80 to 100, the corresponding SpO2 will be 95 to 100. And this is normal, and in COVID it is known as asymptomatic case. Then if the PaO2 is 60 to 80, the corresponding value of SpO2 is 90 to 94, and it is mild hypoxemia, and in COVID classification it is known as mild cases. When the PaO2 is 40 to 60, the SpO2 value will be 75 to 89. It is a moderate hypoxemia, and in COVID classification it has been given as a moderate cases. And when PaO2 is less than 40, the value will be, SpO2 value will be less than 75. It is known as severe hypoxemia, and in COVID classification, this patient is known as severe cases. So depending upon the hypoxemia, the COVID has been classified. Now this relation of PaO2 and PaCO2 you cannot find in some condition. So you should have the knowledge of that. A pulse oximeter gives false report when there is shock, when there is nail polish, when there is thick skin, when there is hyperpigmented skin. In all these conditions, the pulse oximeter gives you the false value. Not only this, your hemoglobin dissociation curve, it also says that in some condition there is high value of SpO2, but it is less utilized by the tissue, hypoxic tissue, and there is a low value of SpO2, but it is highly utilized by the hypoxic tissue. And the conditions are raised temperature, raised CO2, raised hydrogen ion means low pH, raised 2,3 biphosphate glycosinate. It is the degradation product of RBC. In this condition, the graph will shift toward right. It is known as Bode effect, and the oxygen from the hemoglobin is easily taken out by the hypoxic tissue. In the same condition, if the patient have high level of carbon dioxide in the opposite condition, in that condition the graph is showing that SpO2 is high, but tissue is unable to utilize that oxygen. So this SpO2 will say about the internal things, internal conditions. In all the condition is not that. So you should have knowledge of this so that you can manage accordingly. Now I told you that anemia is an important factor. They say that if the patient have anemia with dyspnea, blood transfusion is indicated. So in a patient of anemia, you have to calculate the oxygen content. Not only this, I have told you that in COVID infection, it has been found that if the RDDW value, RBC white, RDW is white, the prognosis is bad. So in this condition, what will happen? The oxygen carrying capacity is low. If you will see oxygen, the oxygen level will so high, but it is not proper for the patient. So it is not proper for the survival of the organ. So in that condition, if there is anemia, you decide the oxygen content, and the formula is hemoglobin, that is gram per liter multiplied by 1.34 multiplied by percentage of SpO2, means SpO2 divided by 100, and this value is the plasma oxygen 0.003 multiplied by PaO2. This is the plasma oxygen. So this oxygen should be 200 milliliter per liter of blood in a 72 kg person. So if the weight is low, you calculate accordingly what should be the oxygen value of the patient and what is there. So in a COVID infection, if you find that the patient have anemia and oxygen content is low, urgently blood transfusion should be done to revive the patient. Not only that, from this oxygen content, you can derive the oxygen delivery by multiplying the cardiac output. So oxygen delivery is equal to cardiac output multiplied by oxygen content, where cardiac output non-invasively you can get from echocardiography. And from this oxygen delivery, you have to know about the diffusion defect which occurs in the cases of shock. Now, this is all help in the diagnosis, severity, type, and all the things about the gas analysis, but there are also electrolyte analysis and acid-base analysis. If there is associated comorbidity, the ABG will say about that. Suppose a patient have high anion gap metabolic acidosis. The causes is mud piles. Mud piles is mnemonic, M for methanol, U for uremia, D for diabetes, P for paraldehyde, I for ischemia, infection, isoniazide toxicity, E for ethanol, and S for salicylate. So these can be the cause. If associated high anion gap metabolic acidosis, you exclude what is the cause in it. Uremia is the more common. The diabetes is more common. Is the patient suffering from diabetic ketoacidosis, and you have to manage it urgently to revive the patient. Now the second condition can be non-anion gap metabolic acidosis. It occurs in two conditions. One is renal tubular acidosis and another one is diarrhea. You take the history like that and see the routine examination to exclude that. Metabolic alkalosis. If you get metabolic alkalosis, you see the hydration state of the patient clinically and by ABG also. So if the metabolic alkalosis is associated with dehydration, it means high level of diuretics and darbepoetin has been used. If there is metabolic alkalosis with hydration, it is almost always due to endocrinal disease. And in endocrinal disease, you have Cushing syndrome and Cunning syndrome, and you know Cushing syndrome, iatrogenic Cushing is the most important, and you know in the corticosteroid is the common use in the COVID infection. So if the patient have metabolic alkalosis with hydration, you can think that it is due to side effect of the corticosteroid. Now the respiratory alkalosis you can get, it occurs in LED, ABP, HF. LED means L for liver disease, E for embolism, D for drugs, A for anxiety, V for ventilatory effect, P for pregnancy, and heart failure. So if it is severe, although in the cases of hypoxemia there is increased rate of respiration, so a wash out of carbon dioxide, so it can be due to hypoxemia itself. So all the things that what is the real picture in it. Now the respiratory acidosis, I talked to you that emphysema lung causes from CNS to neuromuscular junction can be the cause. In old age, electrolyte disturbance is very common. So it gives you the idea about electrolytes, and at the same time, you can know about the anemia of the patient in simple ABG finding. It says you about the prognosis. In type 1 respiratory failure, if the cause is shunt, prognosis is not good. If it is due to ventilation perfusion mismatch, prognosis is not bad. In type 2 respiratory failure, if associated with severe hypoxemia, if associated with severe acidosis, the pH is less than 7.2 and the rate of respiration is more than 32, the prognosis is not good. In acute exacerbation of COPD, if pH is less than 7.2 and if vent has not been applied, mortality is about 100%. So, respiratory failure with metabolic acidosis, prognosis is not good if the cause of metabolic acidosis is not known. Because in the cases of metabolic acidosis, the control of acidosis by giving bicarbonate is not the proper way. It is to treat the cause in this condition. That is important. So, you have to find the cause and you have to treat the cause. Health in management plan, I talked to you that if PaCO2 is less than 60 millimeter of Hg, you use nasal cannula, face mask, non-rebreathing mask. Apply NIV, CPAP in type 1 respiratory failure, BiPAP in type 2 respiratory failure. If a patient of type 1 respiratory failure is exhausted, it can go into type 2 respiratory failure. And in that condition, you have to apply BiPAP. If not tolerating or not improving, immediately switch over to vent. So, in a patient, 1 liter of oxygen gives 3% of oxygen. So, 1 liter is almost 3% above the atmospheric percentage, that is 21%. So, if a patient is on FiO2 60%, that comes to 13 liters per minute for 2 hours, and if PaO2 is not improved to more than 60 millimeter of Hg, you ask for the ventilator. Type 2 respiratory failure is only condition where slow flow oxygen 24 to 28% is given. Otherwise, in all conditions, high flow oxygen is given. So this is the only one condition and in a selected case. Because if there is severe type 2 respiratory failure, in that condition, the carbon dioxide is not have not the effect of producing ventilation. It is the hypoxic drive which causes the ventilation in that condition. So if you will overcorrect the patient with oxygen, so what will happen? That drive will come down and the carbon dioxide will go up. So in selected cases, this thing can happen. You will give oxygen to type 2 respiratory failure and the carbon dioxide will go high. So what are the indication of ventilator? Who is intolerant to PAP device and oxygen is not maintaining through NRM and high flow nasal cannula? Type 2 respiratory failure with pH less than 7.2. The hypoxemia index is less than 100, even with FiO2 60% through CPAP or for 2 hours. And when there is SpO2 is less than 90%, with rate of respiration more than 40 can cause exhaustion to the patient, so ventilator is indicated. But here remember, the ventilator in the cases of COVID cases should be given by tracheostomy, because it will take time. Self-resolution occurs in this condition, so it can take 14 days to 20 days time. So if you are giving oropharyngeal route, in that condition the patient is not going to tolerate it more than 2 to 3 days, one thing, and the nutrition becomes difficult to give. If you are using tracheostomy by giving endotracheal tube through tracheostomy, you can save the patient for longer period to resolve. Although outcome in any condition is not good. So monitor in ventilated patients. You should know the monitors are clinical monitoring, that is pulse, BP, respiratory rate, temperature, SpO2, input, output, and plasma glucose. It is recorded in a chart, and that chart is known as Schuch chart. The ventilatory setting monitoring, the ventilatory settings you can change to have control over PaO2, PaCO2 and pH by mode, tidal volume, frequency, IE ratio and FiO2. ABG monitoring, it is a monitor also in a ventilated patient, that is PaCO2, bicarbonate, pH and PaO2, and the circulatory monitoring by central venous line, pulmonary wedge pressure, intra-arterial pulse and BP. Traditionally, ABG is confined to ICU mainly for monitoring. Why? Then your question will be why? Because if the ABG has so many roles, why it is confined to ICU? Exactly what happens in a cases of multi-organ disease. The ABG diagnosis sometimes does not match with that of clinical diagnosis, and the clinicians say that ABG is inappropriate. Because the accuracy of ABG can be tested by one method. That is the difference between derived bicarbonate and the measured bicarbonate should fall in between plus minus 2. That is the test for accuracy, but no ABG machine measures the bicarbonate. This is the main problem. Now, I have given, my paper is waiting in an international journal is under peer review that says about the accuracy of ABG, how can you know? And that is why this ABG, which is for use in the emergency department, is only confined to ICU and used as a monitor only. So this is the main drawback of this ABG to be used. So early referral. Now you have diagnosed, you have taken ABG and have matched the clinical diagnosis. You have planned the management. Then you have to reassess the patient after some hour, that if your patient is improving or not clinically and through ABG. If the patient is not improving, you refer the patient early to higher center. It is going to deteriorate later on. So get home message is the cause of dyspnea can be the cause of dyspnea, which is difficulty in respiration or tachypnea, can be cardiac, respiratory, anemia, metabolic, hyperventilation syndrome. All can, if a patient have all disease, ABG can exclude that what he is suffering from. So ABG is a single investigation which can tell you about the cause of this dyspnea. So in all cases of dyspnea, the ABG should be done and analysis should be done properly. Almost in all cases, clinical findings can be correlated with ABG findings, and proper management of the patient from very beginning of admission can save much more life. Thank you very much.